Hello, Assalamu alaikum class. I hope you're all doing fine. So now we are going to continue with the topic of our lecture about the elbow. Now objective is to give you a better understanding of the structure and function of the elbow and the other joints. You will have knowledge about the movement of the upper extremity. And finally, the next main objective is to give information about loads on this specific joint that occur. So that we have discussed before moving forward. So let's discuss the elbow. Now, numerous muscles cross the elbow, including those that cross the shoulder or extend into the hands and the fingers. So these are the prime movers of the elbow. First movement is flexion and extension. Now, the muscle crossing the anterior side of the elbow are the elbow flexors. Now, normally, the strongest of the elbow flexors is considered to be the brachialis muscle. Since the distal attachment of the brachialis is the coordinate process of the ulna, the muscle is equally effective when the forearm is in supination or pronation. Although evidence does suggest that during supination, uh, biceps is generally more efficient. Another elbow flexor was the biceps brachii, with both long and short heads attached to the radial tuberosity by a single common tendon. The muscle contributes effectively to flexion when the forearm is supinated because it is slightly stretched. When the forearm is pronated, the muscle is less taut and consequently less effective. Number three, the brachioradialis. A third contributor to the flexion at the elbow, this muscle is most effective when the forearm is in neutral position, the midway position, because of its distal attachment to the base of the stellate process on the lateral radius. In this position, the muscle is in slight stretch and the radial attachment is centered in front of the elbow joint. Now we will talk briefly by extension. The major extensor of the elbow is the triceps muscle, which crosses the posterior aspect of the joint. Now, although the three heads of the triceps have separate proximal attachments, they attach to the olecranon process of the ulna through a common distal tendon. Even though the distal attachment is relatively close to the axis of the rotation of the elbow, the size and the strength of the muscle makes it effective as an elbow extensor. The relatively small inconius muscle, which courses from the posterior surface of the lateral epicondyle of the humerus to the lateral olecranon and the posterior proximal ulna, also assists in extension. Research has shown that the lateral and medial head of the triceps contribute to 70 to 90% of the extension movement, with almost 15% contribution by the inconius muscle. The long head of the triceps, crossing both the elbow and the shoulder, was found to contribute significantly less than other muscles. So this is something to note about, that the two joint crossing long head of the triceps is relatively less significant in elbow extension. Now we will talk about the supination and pronation. Pronation and supination of the forearm involves rotation of the radius around the ulna. Now, you should know that there are three radioulnar articulations: the proximal, middle, and the distal radioulnar. Both the proximal and the distal joints are the pivot variety, but the middle radioulnar joint, is a syndesmosis, at which an elastic interconnecting membrane permits supination pronation but prevents the longitudinal displacement of the bones. The major pronator is the pronator quadratus, which attaches to the distal ulna and the radius. When pronation is resisted or rapid, the pronator teres crossing the proximal radioulnar joint assists. Now, as the name may suggest, supinator is the muscle primarily responsible for supination. It is attached to the lateral epicondyle of the humerus and to the lateral proximal third of the radius. When the elbow is in flexion, tension in the supinator lessens and the biceps assist with supination. When the elbow is fixed at 90 degrees or less, biceps is positioned to serve as the supinator. This was class a brief revision about the movements that we studied at the elbow joint. Now we will briefly discuss about the load. I have discussed about it before, but I would like to shed some light or greater detail on the topic as I think it is necessary. Now, even though the elbow is not designed to be a weight-bearing joint, it is regularly sustained large loads during activities. Example would be compressive loads at the elbow, which are about 300 Newton during dressing activities and 1700 during when the body is supported by arms or rising from the chair. Even greater loads are present during the execution of selected sports skills. Example would be during baseball pitching. Also, during the execution of gymnastic skills such as the handspring and the vault, the elbow functions as the weight-bearing joint. Research indicates that the maximum isometric flexion when the elbow is fully extended can produce joint compression forces as much as 2 times the body weight. Now, since the attachment of the triceps tendon to the ulna is closer to the elbow joint, uh, more to the center than the attachment of the brachialis on the ulna and the biceps on the radius, the extensor movement arm is shorter than the flexor movement arm. As you can see in this image here, extensor movement arm is less than the flexor movement arm. This means, class, that the elbow extensors must generate more force than the elbow flexors to produce the same amount of joint torque. This translates to larger compression forces at the elbow during extension than during flexion, when the movements of comparable speed and force requirements are executed. Now, another thing, because of the shape of the electron process, the triceps movement arm also varies with the position of the elbow. It is seen that the triceps movement arm is larger when the arm is fully extended than when it is flexed past 90 degrees. I would also like to give you a brief overview of the injuries related to the elbow that I think you should know about. For example, let me give you an example, sprains and dislocations. Forced hyperextension of the elbow can cause posterior displacement of the coronoid process of the ulna with respect to the trochlea of the humerus. Such a displacement stretches the ulnar collateral ligament, which can sprain. Also, continued hyperextension movements of the elbow can cause the distal humerus to slide over the coronoid process of the ulna, resulting in dislocation. Now, although the dislocation of elbow do not occur frequently as dislocation of the glenohumeral joint, elbow dislocation occurring in individuals under the age of 30 are most likely to arise during participation in sports activities. The common mechanism seen is a fall on the outstretched hand or a forceful twisting elbow. Fall is on the outstretched hand like this, or the elbow twists. The subsequent stability of a once dislocated elbow is impaired, particularly if the dislocation was accompanied by humeral fractures or rupture of the ulnar collateral ligament. Elbow dislocations in young children about age 1 to 3 are called as nursemaid elbow or pulled elbow. Adults should avoid lifting or swinging young children by their hands, wrist, or forearms, as this type of injury can occur. Now, overuse injuries. With the exception of the knee, the elbow joint is the most commonly affected by overuse injuries. Stress injuries to the collagenous tissues at the elbow are progressive. The first symptom is usually inflammation and swelling, followed by scarring of the soft tissues. The condition is progress further, calcium deposits may accumulate, and the ossification can occur. Now talking about a few conditions. One is the lateral epicondylitis. It involves inflammation or micro damage to the tissues on the lateral side of the distal humerus, including the tendinous attachment of the extensor carpi radialis brevis and possibly that of the tensor digitorum. Although a host of factors may contribute to the development of the condition, overuse of his wrist extensors is cited as the major culprit of the disease. Now, because of the relatively high incidence of lateral epicondylitis among tennis players, the injury is commonly referred to as tennis elbow. You must have heard of it. Reported 30 to 40% of tennis players develop lateral epicondylitis. Onset is usually 35 to 50 years of age. The amount of force to which the lateral aspect of the elbow is subjected to during tennis play increases with poor technique and improper equipment. Apart from that, activities such as swimming, fencing, hammering can also contribute to lateral epicondylitis. Medial epicondylitis is called the little league's elbow, another condition that you should know of. It is the same condition but on the medial aspect of the distal humerus. Here. For example, during pitching, the valgus strain imparted to the medial aspect of the elbow during the initial stage, when the trunk and shoulder are brought forward ahead of the forearm and the hand, contributes to the development of this condition. The valgus torque decreases with the late trunk rotation, reduces external rotation of the throwing shoulder, and the increased elbow flexion. Medial epicondyle avulsion fractures have also been attributed to forceful terminal wrist flexion during the follow-through phase of the pitch. More commonly, however, throwing injuries to the elbow are chronic rather than acute. Injuries or stretching of the ulnar collateral ligament can result in valgus instability, which with repeated valgus overload during repetitive throwing can provoke the development of bony changes that can further exacerbate the problem. Although uncommon among athletes in general, valgus instability is seen with higher incidence in individuals who throw repetitively. Medial and lateral epicondylitis now can occur with about equal frequency in golfers, particularly the amateur ones. Lateral epicondylitis may be related to the gripping of the club with excessive pronation of the right hand, with the medial epicondylitis appear to be associated with repeated striking of the ground with the club. Now class, we will continue forward with our new topic, that is the structure of the wrist. You should know that the wrist is composed of radiocarpal and intercarpal articulations. The radiocarpal and the intercarpal articulations. Most wrist motion occur at the radiocarpal joint, which is a condylite joint, where the radius articulates with the scaphoid, the lunate, and the triquetrum. The joint allows sagittal plane motions, flexion, extension, and frontal plane motions like radial and ulnar deviation, and the circumduction, which is a combination of both. Its close packed position is in extension with radial deviation. Now, there is a cartilaginous disc that separates the distal head of the ulna from the lunate and the trochlear bones and the radius. Now, although this disc is common to both the radiocarpal joint and the distal radioulnar joint, the two articulations have separate joint capsule. The radiocarpal joint capsule is reinforced by a volar radiocarpal, dorsoradiocarpal, radial collateral, and ulnar collateral ligaments. Intercarpal joints are the gliding type of variety of joints. They contribute little to wrist motion, but nonetheless they have some minor role. Now, the fascia around the wrist is thickened into strong fibrous band called the retinaculum or retinaculum, if you remember. Now, this forms a protective passageway through which the tendon, nerves, and the blood vessel pass. The flexor radiculum protects the extrinsic flexor tendons and the medial nerves which they cross the palmar side of the wrist. On the dorsal side of the wrist, the extensor reticulum provides a passageway for the extrinsic extensor tendons. This is the structure of a wrist. This is the radiocarpal joint, the intercarpal articulations. As you can see, this is a gliding gluteus joint, and this is a condylite permitting specific movements of flexion, extension, radial and annular deviation. Now we talk about the important and necessary movements in the wrist. The wrist is capable of sagittal and frontal plane movements as well as rotatory movements. Flexion is the motion of the palmar surface of the hand towards the interior forearm. Extension is the return of the hand to the anatomical position, and in hyperextension, the dorsal surface of the hand approaches the posterior forearm. So this is flexion, extension, hyperextension. Movement of the hand towards the thumb side of the arm is radial deviation, with the movement in the opposite direction, the ulnar deviation. Movement of the hand through the all four directions produces circumflexion. Because of the complex structure of the wrist, rotational movements at the wrist are also complex, with different axes of rotation and different mechanisms through which that motion occurs. So first movement that I would like to discuss, class, is the flexion movement. Flexion. The muscles mainly responsible for flexion at the wrist are the flexor carpi radialis and the powerful flexor carpi ulnaris. The palmaris longus, which is often absent in one or both forearms, contribute to flexion if present. All three muscles have proximal attachment on the medial epicondyle of the humerus. The flexor digitorum superficialis and flexor digitorum profundus can assist with flexion at the wrist when the fingers are completely extended. But when the fingers are in flexion, the muscle cannot develop sufficient tension. Why? Because of active insufficiency. We have studied numerous times, class, the concept of active insufficiency, how it works, how there is actually slack or inability to produce tension when muscle contracts simultaneously at two joints. This is flexion at the wrist. This is a brief understanding of the movements and the muscle attached. As you can see here, palmaris longus, flexor digitorum superficialis, flexor digitorum profundus, flexor carpi radialis. This is the movement, flexion, back extension, beyond that hyperextension, towards the thumb radial and away ulnar. Now let's talk about extension at the elbow or at the wrist joint and hyperextension as well. Now, extension and hyperextension at the wrist results from the contraction of the extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. These muscles originate on the lateral epicondyle of the humerus. The other posterior wrist muscle may also assist with the extension, particularly when the fingers are in flexion. Included in this group are the extensor pollicis longus, extensor indicis, extensor digiti minimi, and extensor digitorum. These are the muscles, as you can see: extensor carpi ulnaris, extensor carpi radialis brevis, and extensor carpi radialis longus. These are the main muscles that produce extension. Now, another movement that is to be discussed is the radial ulnar deviation. Now, radial ulnar deviation is the cooperative action of both flexor and extensor muscles that produces lateral deviation of the hand and the wrist. So, on the radial side, the flexor carpi and the extensor carpi contract simultaneously to produce the radial movement. The flexor carpi radialis and extensor carpi radialis longus and brevis contract to produce radial deviation. And flexor carpi ulnaris and extensor carpi ulnaris cause ulnar deviation. So it means that the radial ulnar deviation is actually the cooperative movement of both the flexor component and the extensor component of your hand. On that note, before moving forward, let me give you a brief overview that the main flexors are the carpi radialis, ulnaris, palmaris longus if present. Digitorum superficialis and digitorum profundus assist, but as they cross the fingers, their assistance is affected by how the fingers move. Finger extension, they perform well. If fingers are in flexion, their performance is poor. Extension, extensor carpi radialis longus, radialis brevis, extensor carpi ulnaris, with other assistance from wrist extensor muscles. Medial and radial ulnar is the contribution or cooperative movement between the flexor and the extensors of both sides. Now let's talk about the structure of the next topic, the structure of the hand and the joints of the hand itself. Now, a large number of joints are required to produce the extensive movement capabilities of the hand. This includes the carpometacarpal, intermetacarpal, metacarpophalangeal, interphalangeal joint, etc. The fingers are referred to as digits as 1, 2, 3, 4, 5. The first digit is unique and it is called the thumb. First joint that I would like to discuss with you is the carpometacarpal and the intermetacarpal joints. The carpometacarpal joint of the thumb, the articulation between the trapezium, first metacarpal, is the classic saddle joint. The other CM joints are generally regarded as gliding joints. All carpometacarpal joints are surrounded by joint capsule, which are reinforced by the dorsal, volar, and trochleus carpometacarpal ligaments. The irregular intermetacarpal joints share these joint capsules. As you can see, the carpometacarpal, the thumb is the saddle joint and the rest are gliding vertebral joints. So the thumb is unique. And the intermetacarpal joints, they are between the metacarpals that share the joint capsule with the carpometacarpal joints. Metacarpophalangeal joints. Now, the metacarpophalangeal joints are the condylite joints between the rounded distal heads of the metacarpals and the concave proximal end of the phalanges. These joints form the knuckle of the hand. This knuckle that you see here is the carpometacarpal joint. This is the main indicator of carpometacarpal joint. Now, each joint is enclosed in a capsule that is reinforced by strong collateral ligaments. The dorsal ligament also merges with the MP joint of the thumb as well. Close back position of the MP joint is the fingers and thumb that are in full flexion and opposition respectively. Now about the interphalangeal joints. The proximal and the distal interphalangeal joints of the fingers and the single interphalangeal joint of the thumb. They are all hinge variety of joints, meaning they mainly perform one movement like a hinge, flexion extension. An articular capsule joined by volar and collateral ligaments surround each IP joint. These joints are most stable in the close back position of full maximum extension. This is their close back position. So class, The purpose of teaching you all these movements, all these joints, was to help you or guide you in understanding the unique movements that occur at your hand. Now let's first talk about the movement of the hand. The carpo-metacarpal joint, mainly of the thumb, allows a large range of motion, similar to that of a ball and socket joint. Motion at the seam joints uh, 2 through 4 is slightly constrained or slight due to the ligaments that hold it down, with somewhat more motion permitted at the fifth seam joint, although the metacarpopharyngeal joints of the fingers allow flexion, extension, flexion, extension, abduction, adduction, and circumduction for digits 2 through 5. With an interesting thing for you to know, class, with the abduction is defined as the movement away from the middle finger, and adduction being the movement towards the middle finger. So if my finger moves towards the middle finger, they are called adduction. If away, this is called abduction. This is, class, something unique to the hand movements, that the midpoint is the middle finger, the midline through which the movement occurs, not the reference central point of the body. This is unique for it. Now, because the articulating bone surfaces at the metacarpopharyngeal joint of the thumb are relatively flat, the joint functions more as a hinge joint, allowing only flexion and extension. The interpharyngeal joints. The interpharyngeal joints permit flexion and extension, and in some individuals, a bit of hyperextension. These are the classic hinge joints. Now, due to passive tension in the extrinsic muscles, when the hand is relaxed and the wrist moves from full flexion to extension, the distal interpharyngeal joint goes from approximately 12-31 degree of flexion, and the proximal interpharyngeal joint goes from about 19 to 70 degree of flexion. I will repeat that again for you. Due to the passive tension in the extrinsic muscles, when the hand is relaxed and the wrist moves from full flexion to full extension, the distal interpharyngeal joint goes from 31 degree of flexion, and the proximal goes about 19 to 70 degree of flexion. Now, a relatively large number of muscles are responsible for many of the precise movements performed by hand and the fingers. This is a repetition of the slides that I would like to go through. The motion permitted at the metacarpopharyngeal joint 2 to 5. This is a revision for you. Flexion, extension, abduction, adduction, and circumduction. Flexion, extension, abduction, and adduction. The purpose of teaching you before is that when you go through the slides, you should have a clear-cut memory of these movements: flexion, extension, abduction, adduction. Abduction is considered when moving away from the midline of, that is, the middle finger, and adduction towards the middle finger. Now about the important muscles that are related to the common function of the hand that you should know. There are basically numerous muscles that you have to know about. So, large number of muscles responsible for many precise movements performed by the hand. Now, the gist that you should know, or the main points that you should know, that there are 9 extrinsic muscles that cross the wrist and 10 intrinsic muscles within both of their attachment distal to the wrist. 9 extrinsic muscles with attachment both proximal and distal to the wrist. 10 intrinsic muscles with both attachment distal to the wrist. If you refer to the book, it has given you a clear examples of these muscles. Let me share with you to refresh your memories. Extrinsic muscles. They are extensor pollicis longus, extensor pollicis brevis, flexor pollicis longus, abductor pollicis longus, extensor indicis, extensor digitorum, extensor digiti minimi, flexor digitorum profundus, and flexor digitorum superficialis. All of these have an attachment to proximal to the wrist and insertion distally at mainly the hands and fingers. What about the intrinsic muscles? They are the flexor pollicis brevis, abductor pollicis brevis, operans pollicis, adductor pollicis, abductor digiti minimi, flexor digiti minimi brevis, operans digiti minimi, the dorsal trochei, 4 muscles, the palmar trochei, 3 muscles, and the lumbricals, that are 4 muscles. Now, this is part of the anatomy class. You are expected to know the name of these muscles, which of these are intrinsic and which of these are extrinsic. The main difference is that the intrinsic muscle begin within the wrist, proximal to the wrist, but they are confined to the hand. They do not cross the wrist. This is the biggest distinction. Extrinsic muscles are originating from your forearm and they cross the wrist and attach to the hand and perform their unique function. Now, what is the important points that you have to know about them? The extrinsic flexor muscles of the hand are more than twice as strong as the strongest of the extrinsic extensor muscles. I repeat that. The extrinsic flexor muscles of the hand are more than twice as strong as the strongest of the extrinsic extensor muscles. This should come as a little surprise, given that the flexor muscles of the hand are used extensively everyday activities, for example, gripping, grasping, pinching movements, while the extensor muscles are rarely exert that much force. Now, the multidirectional force measurement for the index finger shows that the highest force production in flexion with forces generated in extension, abduction, and adduction were 38, 98, and 79 respectively of the flexion force. I repeat that. There was a force measurement for the index finger and showed that compared to the flexion, the forces generated in extension, abduction, and adduction were 38, 98, and 79, showing how strong flexors were. But nonetheless, the strongest of the extrinsic flexor muscle are the flexor digitorum profundus and the flexor digitorum superficialis. They collectively contribute about over 80% of all flexion forces. So class, this lecture was mainly about the commonalities, important points related to the movement of your hands and wrist. Before going forward, I would like to give you a revision, and that will be end of your lecture. Let's start briefly class, a brief revision for you so that you can remember the important points. Remember that the wrist is capable of sagittal and frontal plane movements and rotatory movements as well. Flexion, the motion of the palmar surface of the hand towards the interior forearm. Extension, return of hand to the anatomical position. Hyperextension, the dorsal surface of the hand approaches the posterior forearm. Movement of hand towards the thumb side. Elevation, opposite ulnar deviation. If all movements are combined, circumduction. Now, quickly going through the flexing movements. Flexion is mainly by flexor carpi radialis, flexor carpi ulnaris. Palmaris longus is present, also contributes. Flexor digitorum superficialis and digitorum profundus can assist with flexion, but with when the fingers are extended here, this moment. But when they are flexed, they cannot develop the sufficient tension needed due to active insufficiency. Extension and hyperextension. This results from the contraction of extensor carpi radialis longus, radialis carpi brevis, and extensor carpi ulnaris. They originate on the lateral epicondyle of the humerus, these muscles. Other posterior wrist muscles can also contribute or assist with extension, especially when the fingers are in flexion. This includes the group in these muscles include extensor pollicis longus, extensor indicis, extensor digiti minimi, and extensor digitorum. Then I briefly talked about radial ulnar deviation. This is a cooperative movement between both flexor and extensor muscles. For example, flexor carpi radialis and extensor carpi radialis longus and brevis produce radial deviation. Flexor carpi ulnaris and extensor carpi ulnaris produces ulnar deviation. Then I briefly talked about the structure of wrist and hand. I talked about that a large number of joints are required to provide the extensive movement capabilities of the hand, like piano or hand washing and eating. So the joints included in the hand are carpometacarpal, intermetacarpal, metacarpophalangeal, and the interphalangeal joints. Fingers are referred to as your digits. The carpometacarpal and the intermetacarpals. The carpometacarpal of the thumb is the articulation between the trapezium, and the first metacarpal is the saddle joint. The other are type of gliding joints. All carpometacarpal joints are surrounded by a giant capsule, which are reinforced by the dorsal, volar, and interosseous CM ligaments. The irregular intermetacarpal joints share this capsule. The carpophalangeal joints, condylite joints between the rounded distal head of the metacarpals and the concave proximal end of the phalanges. They form your knuckles that you see here. This is the metacarpophalangeal joint. Now, each joint is enclosed in a capsule that is reinforced by strong collateral ligaments. Now, a dorsal ligament also merges with the MP joint of the thumb. The close back position is in the close back position of the MP joints in the finger and the thumb are full flexion and opposition, respectively. Phalangeal joints, the proximal and the distal, and the single interphalangeal joint. So there is no proximal distal here. This is just one. They are all hinge variety of joints. Now, an articular capsule joined by the volar and collateral ligaments surround each IP joint. These joints are most suitable in the close back position of full extension. Then I talked about briefly the movements. First was the metacarpophalangeal. This joint allows flexion, extension, abduction, adduction, circumduction for digits 2 to 5. Abduction defined as the movement away from the mid finger, adduction towards the mid finger. Now, as the articulating bone surfaces at the metacarpophalangeal joint of the thumb are relatively flat, the joint function more as a hinge joint, allowing only flexion and extension. And remember, the interphalangeal joints permit flexion and extension, and in some individuals, hyperextension is also seen, like here in my thumb. Due to the passive tension in the extrinsic muscles, when the hand is relaxed and the wrist moves from full flexion to full extension, the distal interphalangeal joints move from 12 to 31 degrees of flexion, and the proximal interphalangeal joint goes from 19 to 70 degrees of flexion. This is good for an MCQ point of view class. Finally, there were many muscles that crossed it. Your muscle responsible for moving your hand movements, performing the hand movements. 9 extrinsic, 10 intrinsic, with the extrinsic flexor muscles being more than twice strong as the extrinsic extensor muscles. What were those extrinsic and intrinsic muscles that you should know? Extensor pulsus longus, extensor pulsus brevis, flexor pulsus longus, abductor pulsus longus, extensor indicis, extensor digitorum, extensor digiti minimi, extensor digitorum profundus, and flexor digitorum superficialis. What about the intrinsic muscle? Flexor pulsus brevis, abductor pulsus brevis, openus pollicis, adductor pollicis, abductor digiti minimi, flexor digiti minimi brevis, openus digiti minimi, the dorsal interosseous 4, palmar interosseous 3, and the lumbricals 4 muscles. These are the muscles mainly responsible for the intrinsic muscles. For you class, it is very important that you should be able to differentiate between each and every one of them easily, as these questions are definitely important for MCQ point of view. This is enough for the lecture for today. If you have any question class, we will discuss this in the interactive session. I hope this was a productive session and hope to see you forward in the future. Goodbye.